including policy and trauma-informed care. She has informed the measurement of discrimination and advancement of cultural safety in Canadian healthcare. So over to you, Colleen.
Great, thank you. What a lot of hard acts to follow, eh? So today I'm going to have an opportunity to talk to you about work we've been doing to try to equip healthcare for equity. And the problems that we're tackling are huge widening social inequities in Canada that translate into healthcare inequities. And the fact that healthcare systems are really effectively designed for some groups much better than others. So specific groups, for example, people that have experienced high levels of trauma and violence, many of whom we've heard about today, experience getting less care, less accessible care than others, and that's what we're really trying to tackle. People who are racialized, anticipate stigma, people who have been incarcerated, people who live in poverty, all of these groups have what we call inverse care, where those who need the most, in fact, actually get the least. One of the most sort of devastating examples to me is the case of Mr. Brian Sinclair, who was left waiting in a Winnipeg emergency room for 34 hours and died while he was waiting, had never been seen, and he died of a treatable urinary tract infection. And, this is, the judge who saw the case said they wouldn't admit the evidence around the fact that systemic racism was very much playing a role. And we see this kind of stigma operating in many different settings. So sometimes we think that people who don't access prenatal care, for example, that somehow they're to blame, as opposed to it being a matter of access, anticipated discrimination, and real experiences of discrimination. So what we're aiming for is not equality, not treating everybody the same, but rather aiming for equity, where we really reach out and try to serve those people who need the most with the best kind of care. And we think that the way to do this, and we learned this by studying where high quality care is delivered to highly marginalized populations, and we think what equity-oriented care requires are these kind of three things: trauma and violence informed care, culturally safe care, a harm reduction approach, all tailored to the context. So just for an example, one of the settings that we've studied, the patients themselves were so frustrated and angry about how they got appointments. They'd have to line up in the rain, and drug dealers would sort of treat them poorly, if you will, encourage them to get certain prescriptions. Passersby, more affluent passersby, would demean them. It was not a good picture. And with the input of the patients, with this orientation to structural violence and attending to trauma and violence-informed care, they were able to just do some small, inexpensive shifts so that people could wait in warmth and with dignity. And who led that was not the nurses, not the physicians, but it was the medical office assistants that saw how they could actually transform care in a small but meaningful way. So we've studied whether or not this makes a difference, and this has just been published in Millbank Quarterly. And what we were able to show, and it's the first paper that's done it, is doing this kind of care, equity-oriented care, isn't just a nice-to-do thing. It's something that actually translates into meaningful health outcomes. So we already know that staff really overall want to provide really excellent care. They want to do it, but they don't always recognize inequity. They might see patients as difficult or challenging or whatever, but they might not see the inequities or the things that are behind various behaviors, and they don't necessarily know what equity-oriented care looks like. So what we've tried to do is create a whole toolkit of strategies that any kind of organization can use. So, for example, we try to get people started on rating their organization in terms of equity, teaching them how to do an equity walkthrough where they see where their strengths are and where there are areas for improvement. We have things that are aimed at how do you improve the environment and the organization, and then how do you improve your language and the way you talk to people when you anticipate that providing care might be challenging. We also sort of are trying to develop ways to support individual providers with strategies to work with people who experience discrimination, anticipate stigma, and so on. And so we've got all these little pocket cards that just help providers kind of shift their language a little bit. More importantly, though, are the organizational level changes. So one of the organizations we work with, what they did, they were experiencing quite a bit of aggression and so on in their waiting room, and they did two things. They created a separate space for children and families with small children, and they hired an Indigenous elder to work in the waiting room, and everything just went, it was much less expensive than a security guard in bars, by the way. But what the key to success is, first of all, frontline ownership. We have to have the staff that are actually directly engaged in providing care, leading changes, and making these kinds of assessments. The second, and this isn't going to surprise you after the other presentations today, second thing we have to have is patient engagement. If we don't have the actual people who we're trying to serve better guiding the way, then it's not going to be successful. So over and over again, we've had the best ideas and the most crucial problems identified by the people we're trying to serve. So two of the organizations we work with have implemented some kind of chronic pain group. So instead of physicians and nurses